Good morning, good afternoon, or good evening, depending on where you are on the planet. In our days, technology allows us to join people from around the world and join forces. I'm Fotiz from Thessaloniki, Greece, and I would like to welcome you in this joint Asia-Pacific Glaucoma Society and European Glaucoma Society webinar session. As Vice President of the European Glaucoma Society, I would like to thank Asia-Pacific Glaucoma Society for organizing this meeting and for inviting APGS to join. APGS is very pleased to contribute, and both societies developed in close collaboration a very interesting agenda for this session. Also, we were fortunate to have with us today excellent speakers, experts in the field. I will now turn to my co-moderator, Dr. Fang from APGS, who is gonna introduce the society.
Thank you, Fotiz. I'm Dr. Fang from Kuala Lumpur, Malaysia. I'm the current secretary of the Asia Pacific Glaucoma Society. Just a bit of introduction on our society. We actually formed in 2011. Before that, we had three glaucoma societies in the Asia Pacific region. And our mission is to promote excellence in the diagnosis, care of patients with glaucoma in the Asia Pacific region. And this webinar is one of them, one of the aims of our APGS. And we encourage all of you to join our society. As you can see later on, we also have Asia Pacific Glaucoma Guidelines, which is now in the 3rd edition. The EGS now has the 5th edition going to be launched. And we are going to organize a series of webinars, which includes collaboration with societies like the EGS, the American Glaucoma Society, and also the International Society of Glaucoma Surgery. And these are some information on how to contact us and join the society. And we also like to welcome all of you to the Asia Pacific Glaucoma Congress next year in Kuala Lumpur between 13 to 15 of August. And hopefully we can meet face to face. And we have also invited the EGS to run a symposium in this meeting. I would like to pass this time back to Professor Topouzis to introduce the first speaker.
Thank you. So our first speaker is Professor Carl Traverso from Genoa, Italy. Professor Traverso is chairman of the Department of Ophthalmology at the University of Genoa, Italy. And his topic, the opening topic of this session, is new ways to build guidelines, the added value of evidence-based medicine.
Good morning, or actually good afternoon or good evening, depending on your time zone. I am honored to be here sharing with you some of the topics of the guidelines for glaucoma, new ways to build guidelines, and the added value of evidence-based medicine. And let me also thank the Asia Pacific Glaucoma Society for assigning me this task. There is no conflict or financial interest that concerns my presentation of today. In 1997, the European Glaucoma Society started to tackle the issue of terminology, disease definition, and management guidelines for glaucoma. But how did it go since then? Well, it went ahead based on consensus, common sense, standard of care, and evidence. And the first edition had a group of authors that had the task of compiling them. We were fortunate enough at that time to be standing on the shoulders of giants that really were instrumental into making the process functional. And we had several meetings, and we ended up with a reasonable product. The target IOP definition that was composed at that time was based on consensus, the mean IOP obtained with treatment that prevents further glaucomatous damage. The second edition started to have a slightly larger group of authors, and many external suggestions by experts were requested and obtained. In the second edition, one of the major difficulties was to differentiate between first choice treatment and first line treatment. So we decided that we were going to use a little bit of semantics. So first choice treatment was the drug chosen by the physician to be used initially, while the first line was the drug that the regulatory agency defined as the first one to be used. So we arrived then at the third edition, and the contributors and reviewers and the task force were getting larger and larger. And with contributions with several people, and also we put together a team really to make the guidelines. That was the first time in which a simplified grading system for rating the strength of recommendation of the quality was adopted. It was very simplified, strong or weak recommendation, and evidence high, moderate, low, or very low. Consensus from the panel would be graded as B, very low evidence. I give you an example. There is no evidence, scientifically speaking, whatsoever that doing gonioscopy is any good. And that is, though, a strong recommendation. So we arrived then at the fourth edition. The fourth edition had an even larger group of people that contributed to that. We had a formal task force, really as a production team, and writers and contributors were really many. I'll give you an example of the evolution. This is the target IOP diagram. This is how it was in the first edition. 3 main factors. In the second edition, factors were still 3, but we realized that we had put the arrow with the wrong colors in the first edition, like higher target should be green and lower target should be red. So we continue with the following edition, and we added rate of progression as a component of this decision-making process. And then in the fourth edition, we added the additional risk factors. So this is just to show you the evolution of a very more or less simple graph. The mission statement had little changes in the four editions, but what has been there is the concept of quality of life, sustainable cost, and also a message not to overtreat patients, because patients with early to moderate glaucoma damage have good visual function and very modest reduction in quality of life. So the EGS Guidelines 2020, how to evolve from the current fourth edition, which was very successful, resulted from the collaboration of 45 glaucoma experts from Europe and was translated into 12 languages. So how to revise such a successful product, where you're damned if you do, damned if you don't. But we decided to give it a try. First of all, we thought that we should address questions and try to give answers. However, the nonlinearity of the behavior of the clinical disease defies the adoption of formulas, and the prediction in individuals is always very complex. And we have to acknowledge the merit of Augusto Zuara-Blanco as editor of the 5th edition, because he introduced the concept of a new process, which was define the scope and the planned recommendation. Each recommendation should answer a healthcare question important for clinical practice and patients. The recommendation should be based on the best available body of evidence, which is systematic reviews. So in the 5th edition, we put key questions on diagnosis, monitoring, and treatment which were identified and prioritized by a group of experts. The evidence was gathered using the methodology of the Cochrane Eyes and Vision Group, USA and Europe, and the rest of recommendation and suggestions throughout the text of the new 5th edition of the guidelines is derived from consensus among experts. Only references with high quality systematic reviews, landmark glaucoma trials were included. The Glaucoma UK charity has helped us to confirm the most important questions and the most common concerns for patients. Decision-making ultimately should be individualized, ideally guided by best available evidence, which are the systematic reviews. I will not go through the great process that was directed by Augusto and implemented throughout. However, the recommendations were either strong or weak, and the amount of work that was done is enormous. Almost 18,000 records were analyzed, and resulting in about 50 systematic reviews that were usable. And this was an enormous work from a group of people that are knowledge here and all coordinated by Augusto Azuara Blanco. So here we are. This is the final product, the European Glaucoma Society Terminology and Guidelines for Glaucoma, 5th edition. Let's give an example of a few of the questions that were addressed. Alternative tonometers other than Goldman applanation tonometry, are they recommended in clinical practice? Strength of recommendation, weak. Level of evidence, very low. Consensus could not be reached. Why? In general, all measurements with tonometers which applanate the cornea are influenced by corneal biomechanics. The recommendation on central corneal thickness. Is it recommended to use central corneal thickness to risk profile patients? CCT may be useful for baseline risk profiling. Low evidence, weak recommendation. There is no strong evidence that CCT is an independent risk factor. IOP correction algorithms based on CCT are not validated and should be avoided. Medical treatment. What is the most effective and what is the first choice medication for open-angle glaucoma? Recommendation, prostaglandin, analog. Evidence is high for IOP reduction, but very low for other outcomes. Strong recommendation. Comment. We need to consider other factors. Think about the individual patients. Is selective laser trabeculoplasty recommended as initial treatment? There is one high-quality trial and other trials that show that this is a good procedure to be offered as initial treatment. However, SLT and argon laser trabeculoplasty probably have similar efficacy. And another novelty of the 5th edition is that we dedicated one full page to things to avoid, choosing wisely. And there are several topics there, like short wavelength automated perimetry and routine genetic testing and glaucoma management decision based on artificial intelligence, or lowering IOP to just below 21 millimeter in advanced glaucoma. And these are all things that are put together from consensus, scientific evidence, standard of care, and common sense. The group that has produced this work is very large. We had a meeting in which the first draft of the guidelines was written, and then a lot of work in the background. See, from November till now, we have had 1,400 emails exchanged on this topic, and additional contributors from outside the European Glaucoma Society and from inside and from other from other people. In my clinic, a group of people contributed to the medical editing and illustration. And as Anya Tuulonen has said many times in the past, teamwork divides the task and multiplies the result. In conclusion, I think that the European Glaucoma Society Guidelines project that has now reached the 5th edition is a good example of teamwork and of international cooperation, witnessing that possibly ophthalmologists are much better than politicians. You are all invited mid-December to the European Glaucoma Society meeting in Brussels, where this topic and others will be discussed. And I thank you very much for your attention.
Now we're moving on to the next presentation, the second presentation in our session. Our speaker is Ananth Viswanathan from UK. Ananth Viswanathan is a consultant at Moorfields Eye Hospital in London and a professor at UCL, University College London. His topic is glaucoma monitoring, what tools to use and how much is enough.
I'm Ananth Viswanathan from Moorfields Eye Hospital in London, and I'm here to talk to you about glaucoma monitoring, what tools to use and how much is enough. So my conflict of interest is that I'm one of the authors, as you see, one of many authors of the EGS guidelines. And this is relevant because this talk is kind of a sneak peek into the forthcoming new edition of the guidelines, which is hot off the press. So the domains I'm going to talk about are the ones we would characteristically use during monitoring. So intraocular pressure, structure, and function. So let's consider each one of these in turn. So first of all, IOP. What do the new guidelines say about intraocular pressure? Well, the current reference standard and the most widely used method for measuring intraocular pressure is Goldman applanation tonometry. Now, other methods, as we all know, are available. They're not given a strong recommendation in the guideline, but that's not because they're disparaged. It's just because of the dearth of evidence. If you read the guidelines in more detail, what they ask you to do is when you're considering a method of measuring intraocular pressure, you should be principally concerned with its precision and its accuracy. And furthermore, during monitoring, you should try to use the same test each time for the same patient. Home testing is now coming more and more to the fore, but there's a recommendation in the guidelines that home measures cannot replace clinical measures carried out in the ophthalmologist clinic. And one of the interesting things about the guidelines is that as well as advising what is best practice, it does have a section on things to avoid, and it gives guidance about things that are perhaps not so good. And one of the things, which has in the little stop symbol there at the beginning of the guidelines, is do not use central corneal thickness correction algorithms, because these have not been validated. So obviously we take account of central corneal thickness, but the algorithms that are around to try and correct intraocular pressure should not be used. What about structure? Well, by structure, principally I mean looking at the disc and looking at the retinal nerve fiber layer. Now, if you need to see contour of the disc, and this is particularly important for the first examination when you might be trying to make a diagnosis, you need a magnified stereo view. And the best ways to get this are either with an indirect non-contact lens at the slit lamp or a direct contact lens at the slit lamp. And usually you have to dilate the pupil to get a good stereo view and see the contour. And the guidelines will give details about all the things you'd expect, how to examine the neuroretinal rim, retinal nerve fiber layer, to look for optic disc hemorrhages, to look for displacement of the vessels, parapapillary atrophy, vertical disc diameter, and vertical cup disc ratio. Interim examinations, so after the first examination, you may not want to necessarily have such a detailed look at the contour of the disc. You may simply be looking for more obvious features like disc hemorrhages. And under these circumstances, it may be fine to look through an undilated pupil. Again, some don'ts that appear in the guidelines pertaining to structure. Do not use cup-disc ratio, either for diagnosis or for diagnosing progression. This is because there is great inter-observer variation in estimation of cup-disc ratio, and also cup-disc ratio is heavily biased by disc size. Optical coherence tomography, as we know, that's a very useful adjunct, both in diagnosis and in looking for progression, but it should not and it cannot replace clinical examination and visual field testing. And a corollary of this is that you should avoid diagnosis based only on OCT. So if the OCT does not fit with the rest of the clinical picture, that classification of outside normal limits on its own should not be enough for you to make the diagnosis of glaucoma. And most OCT progression software does not compensate for the natural aging loss of retinal nerve fiber layer thickness. So that's another note of caution. And of course, finally, as we said with IOP, the results from different instruments are not necessarily interchangeable. So try and stick with the same instrument for the same patient during follow-up. Function, and of course by function we mean perimetry, the visual field. So the standard recommendation is standard automated perimetry. That is the recommended standard. Do not use short wave blue on yellow automated perimetry. So this was at one time held in great hope as something that might be more sensitive at detecting early glaucoma. Turns out that is not the case. So it's not recommended. So white on white, computerized, standard automated perimetry. And usually you use a Goldman size 3 target, and it's usually in the central 24 or 30 degrees. Now, it may be very useful in some cases and from time to time to look, for example, at the central 10 degrees, but the guidelines state that you should not lose the opportunity, you shouldn't sacrifice the opportunity of looking at the central 24 degrees in order to look at the central 10 degrees. By all means, do it if you have extra perimetric resource, but it shouldn't be a replacement for the central 24 or 30 degrees. Patient instruction, particularly on the first visit, is key to getting reliable results. So you need a good environment and you need proper instruction for the patient as to how to do the test and what to expect, and then you'll get more reliable results. You may need to repeat the test, either if it seems unreliable or if it doesn't fit with the rest of the clinical picture. But the corollary of that is, if it is reliable and it does fit, then you don't necessarily need to repeat it. It may be enough to help you make a diagnosis with just the one visual field test at the beginning. And the same applies to follow-up. If they're reliable and they show a pattern, it's something you can believe. Clinically, when looking for progression, trend analysis is probably more important than event. So looking at the slope of the visual field, how it changes over time, is probably more important clinically than looking at change relative to a baseline. Although, as we know, event analysis, looking at change relative to a baseline, has been used in many of the large landmark studies in glaucoma. But clinically, probably trend is better. And for the newly diagnosed glaucoma patient, the recommendation is to do 3 tests per year for 2 years. Either that or to cluster the tests at the beginning and the end of the period of monitoring so that you get statistically better results and more reliable results. But I will reiterate again that this is for people with newly diagnosed manifest glaucoma. So many other patients, so for example, patients with ocular hypertension or patients who have had stable glaucoma for many years, do not need such frequent testing. It may only need to be once or twice, once a year, twice a year, perhaps once every 2 years. I'm going to end with some quotes from the foreword to the new guidelines by George Spaeth. Seems to be odd to put the foreword at the end of my talk, but it's because he gives some useful insights into his own feelings about the guidelines. So he starts off by saying, no written guidelines can apply appropriately to every unique situation, and it's important to bear that in mind. And good clinicians know that care must be personalized to the patient for it to be optimal. He then, though, goes on to say the guidelines provide a general framework on which ophthalmologists can hang pieces of evidence. And that's really the aim of the guidelines. So when you read them, you will see the evidence that has been accrued and the strength of that evidence behind each recommendation. And he also says, even more important than the service to ophthalmologists is the benefit to patients that will result from thoughtful use of these guidelines. So with that piece of wisdom, I will finish. Thank you for listening.
We're now moving on to the third lecture in the session. Our next speaker is Gauti Johannesson. Gauti Johannesson comes from Sweden. He's an associate professor and lecturer at Umeå University and consultant and medical director at Umeå University Hospital. The topic he is dealing with is medical treatment integrating novelties into clinical practice.
Hello, good afternoon or good evening, depending on where you are on the globe. My name is Gauti Johannesson, and my topic is medical treatment integrating novelties into clinical practice. I'll use the new APGS guidelines that you've heard about earlier on in the previous talk in the webinar as basis for my talk. And as Carlo has highlighted in his previous talk, the new guidelines include several novelties compared to earlier versions of the APGS guidelines, as well as compared to other international guidelines. And I'll mention examples from them as I go along. So what's new in pipeline? Well, there is a growing number of new candidates for new glaucoma treatment, although most have not passed clinical trials. There are new novel drug delivery systems that are discussed in these reviews, novel glaucoma devices that are coated with or contain prostaglandins, such as slow-release implants for anterior chamber punctum plugs or ocular rings, all coated with prostaglandins. Some of the reviews discuss also other treatment than intraocular pressure lowering treatment, such as different neuroprotective strategies. So there's a lot going on, but according to the APGS guidelines, none of these are actually have sufficient evidence in order to be able to recommend that treatment for glaucoma. So what is new in medical treatment options? This timeline you can find in the APGS guidelines. And as you can see, in the last 20 years, it seems like there's been a lot of activity. But in fact, it has mainly been new compounds of same classes or fixed combinations. And the new class of netazoidil that was approved in 2018 is actually the first new class in 20 years in glaucoma treatment. So what is netazoidil? Well, it's a Rho kinase inhibitor. It has functions as increasing the trabecular outflow, reduces the intraocular pressure by about 20%, and has several advantages compared to other compounds, such as once daily dosing and mainly local side effects, not so much systemic ones. Netazoidil was approved in the European Union 2 years ago, but it is still not available in European countries for clinical practice, but hopefully that will happen soon. For your information, also there's a fixed combination underway together with latanoprost that will hopefully be approved as well in the near future. So its role in clinical practice is yet to be determined, as it hasn't been used so much yet. Although we're all happy that we have a new class of IOP-lowering drugs, it's important to remember that more isn't always better when it comes to the number of drops for our patients. It's important to remember when you're thinking about the fourth or adding the fifth drop to your patient, the additive effect is usually quite limited, and you must consider surgery when you're thinking about the fourth or fifth drop. If you go along and take the fourth or fifth drop, you need to make sure that the follow-up is tight and swift, so that you can ensure sufficient efficacy in order not to delay surgery unnecessarily. The new EGS guidelines are much about rediscovering existing evidence, because in the new guidelines, information is packaged and delivered in a new way. And one of these is a critical approach to novelties when you're thinking about integrating them into your clinical practice. It's crucial to learn to read the results of the published literature and also listen to the presentations, implementing the criteria of critical evaluation of literature. It's important not to swallow all new hooks, but to question the information given, because it's known that choosing the way results are presented influences the physician's prescription patterns. And as the new EGS guidelines do, it's always preferable to search evidence in systematic research, and that saves time, which is a good thing. And one new thing in the new EGS guidelines that may come to that you might use is the identification of key questions and then evidence-based recommendations to the questions. I'll give you a couple of examples. Here you have medical treatment. What is the most effective and what's the first choice medication for open-angle glaucoma? You get a recommendation that prostaglandin analogues are most effective and usually recommended. Level of evidence is high and the strength of recommendation strong. Another example is SLT recommended as initial treatment. SLT can be offered as first choice is the recommendation. The level of evidence is moderate since there is only one high quality trial, and the strength of recommendation is strong. And in the EGS guidelines, you can find all the landmark RCTs for glaucoma treatment, as you can see here. And at the end of this line, you can see the light trial. And you might be wondering, why is he mentioning laser when we're talking about medical treatment novelties? Well, it's because it's really important when considering medical treatment novelties that you remember that laser is a good option for first choice treatment in glaucoma. The light trial showed that it is effective, at least as effective as eye drops. It's safe and it's cost effective. And speaking of cost effectiveness, this is one thing that has a lot of room in the new EGS guidelines. It's part of the mission statement, and there are recommendations that say to the physicians that every time you thinking of management options, you should consider cost effectiveness in order to provide sustainable healthcare. And this is really crucial because the resources are not endless, and we need to focus the resources to those in need of our resources and not over treat or over diagnose our patients. And obviously, the new guidelines is also the section of things to avoid, choose wisely. And this can be a helpful section to read when related to integrating novelties of medical treatment into your practices. I'm not aware of any other international guidelines that has published similar recommendations. And just to give you an example, here you have one CCT adjusted IOP algorithm should not be used. Glaucoma diagnosis and progression based only on OCT is not recommended, because then we run the risk at having a lot of false positives and missing people due to low sensitivity. And I'll finish off by talking about that overdiagnosis and overtreatment. We all know that there are a lot of underdiagnosis out there in the population. But in modern healthcare systems, we have a huge burden of overdiagnosis and overtreatment. And we need to think carefully when putting a diagnosis on a patient, and not to do this lightheadedly, because we run the risk of inducing anxiety and possible side effects when maybe there is not any need to do that. So, in summary, I would like to just focus on highlighting some issues from the talk. We have a new class of drugs to lower intraocular pressure, the Rho kinase inhibitors. Always have a critical approach when introduced to novelties, medical treatment or other published literature. And I would like to advocate for you to read the new EGS guidelines, because it includes many useful tools and recommendations that you can consider when introducing novelties into your clinical practice. And with these words, I would like to thank you for your attention.
Before going to the next lecture, I would like to suggest to all of you attending the session, please write and send your questions to all 4 lectures, including the next one, because after the next lecture, there will be a Q&A session. So our next lecturer is Professor Ingeborg Stalmans. Ingeborg Stalmans comes from Belgium. She is head of the glaucoma unit at the University Hospitals in Leuven and director of the Laboratory of Ophthalmology, Catholic University of Leuven University. The topic for her lecture is Personalized Surgery, Establishing a Rationale for Choosing.
Hello, I'm Ingeborg Stalmans, and in the next 10 minutes, I will try to establish a rationale for personalized surgery. According to the APGS guidelines, the goal of glaucoma treatment is to maintain the patient's visual function and related quality of life at a sustainable cost. So how can we maintain visual function? Of course, by reducing the intraocular pressure. And the gold standard for glaucoma surgery is still trabeculectomy, because many papers have actually shown its efficacy to lower intraocular pressure. As you can see from these publications, the 1-year outcome of intraocular pressure is very consistently around 12.5 millimeters of mercury. But what really troubles us as surgeons is the complication rates. When you look at this publication from 2002, you see that high rates of complications such as hyphema, shallow anterior chamber, hypotony, cataracts, and even vision loss have been reported. And these are data from the first TVT study, where you also see high rates of early as well as late postoperative complications after trabeculectomy. And even loss of vision in a high percentage of patients. Now, if you look at the more recent publications with the modern trabeculectomy techniques, you see that the rates of complications have considerably gone down. And luckily, also, the rate of vision loss has gone down. What has not gone down is the number of postoperative interventions. In the early publications, as well as the more recent publications using the modern trabeculectomy techniques, you see that we still need to manage the blood, to ensure the long-term favorable outcomes after trabeculectomy. So the surgery that every glaucoma surgeon dreams of is a technique that is fast, easy, effective, with no complications, with a quick recovery and no postoperative manipulations. And this has been described by Professor Kaur as the 10-10-10 procedure, meaning it takes 10 minutes to perform. It brings the pressure down to 10 millimeters of mercury and over at least 10 years. And this is why a lot of efforts have been done to develop alternative glaucoma surgeries, using different routes going from suprachoroidal to Schlemm's canal to the subconjunctival route. But let's take a critical approach here. First of all, about the efficacy of some minimally invasive glaucoma surgeries. If you look at these data from iStent, Hydrus, and CyPass, you see that they also quite consistently provide pressures of around 16 millimeters of mercury, so the higher teens, which is different from the 12.5 after trabeculectomy. And this is a systematic literature review looking at 3 of these angle surgeries, iStent, Hydrus, and CyPass. And when you look at the conclusions about the efficacy of these devices, the authors state that indeed trabeculectomy provides pressures in the lower teens, but with MIGS, higher postoperative IOP levels have been observed. And therefore, the authors suggest that MIGS devices are best suited for patients with mild to moderate disease, in which lower target IOPs are not necessary, or as a method by which patients can reduce their topical hypotensive load. I want to discuss 2 devices separately, and these are the devices that actually use the subconjunctival route. The first publication is about the XEN gel stent, and this is the APEX trial reporting on the 2-year results. As you can see, at 12 months and 24 months, pressures of, here you can see it's 14.9 millimeters of mercury after 1 year and 15.2 millimeters of mercury on average after 2 years were observed. To reach these pressures, a high percentage of patients needed a needling procedure, over 40%. This recent publication actually compares the gel stent with another subconjunctival device, the oppressive flow microshunt. And on this graph, you see the results. After 2 years, the pressures with the XEN were 13.8, so quite consistent with the APEX trial. And with the microshunt, they were at 12.1 millimeters of mercury on average. Now, the next question is about safety. And of course, the elephant in the room there is the CyPass, because we use the term minimally invasive glaucoma surgery because we feel that these devices are safer than traditional trabeculectomy. However, the CyPass study has shown that on the long run, there was a significant loss of endothelial cells, which led to the withdrawal of this device from the market. And this has made us realize that MIGS are not per definition totally safe. So again, from the same systematic review, these were the conclusions about safety. That indeed, MIGS also carry potential risks, and for MIGS devices that use a subconjunctival route, bleb management is still necessary. And that these additional procedures may have an impact on time and outpatient resources and cost. So that brings us to cost, because the APGS guidelines also state that we have to take into account the costs. And the cost of treatment means not only the financial implications for the individuals and society, but also the inconvenience and side effects of the treatment. Again, if we look at the systematic literature review, which also looked at the cost effectiveness, unfortunately, the conclusion was that there is limited availability of information on cost effectiveness. And so there is no cost effectiveness evidence with these devices. Now, we have to realize that the cost includes, on the one hand, financial considerations like device cost, but also surgery time, trained glaucoma specialists needed, postoperative follow-up frequency, and interventions. But also the patient needs to be taken into consideration. And for the patient, other factors are important, like surgical time, bleb manipulation, number of post-op visits, lifestyle limitations, potential risks of vision loss, and bleb dysesthesia. So in conclusion, the one-size-fits-all is inappropriate. And when we choose the right glaucoma surgery for our patients, we have to take into consideration a lot of factors, such as efficacy, safety, cost, but also patient experience and post-op recovery. So the correct attitude, as stated again in the APGS guidelines, are individualized targets and treatments. And actually, in choosing the right surgery for our patients, target pressure is very important. And the guidelines give us guidance on determining the target intraocular pressure. Indeed, they state that we should take into account several factors like glaucoma damage, life expectancy, untreated intraocular pressure, and rate of progression when we choose our target pressure. And this helps us to pick the right surgery. And this is a graph from Ahmed, where he shows the efficacy of the different surgical techniques, and where you can realize that if the patient maybe has a cataract, and especially if there is a narrow angle, you may consider a phaco because it lowers pressure as well. If the patient is on a lot of drops and you want to reduce the burden of treatment, then you might consider using, during your phaco, an internal mix. But if you need lower pressures, for instance, pressures in the higher teens, mid to higher teens, you can consider external mix. But if you need really low target pressures, like 12 or less, then probably trabeculectomy is still the gold standard. So in conclusion, trabeculectomy is effective to lower IOP. Complication rates have come down with modern techniques. Bleb surgery provides low teen pressures, but requires bleb management. And definitely evidence on cost effectiveness is needed. So we need individualized management. One size doesn't fit all, and individualized target pressures can help to make patient-tailored decisions. I thank you for your attention.
Thank you. We would like to thank all speakers for their excellent lectures. We would like to have a discussion around what was said. Let's start from the first lecture. Carlo Traverso presented us on the new guidelines, and it was clearly highlighted in the talk, Carlo, that you said that systematic reviews have formed the basis for making healthcare recommendations in this edition. Because you are in the core of this project, what was the result of this with regards, did the use of systematic reviews make easier to get to a consensus, the experts? Did it challenge common beliefs at some point, or made the experts able to provide with more solid guidance for the reader?
Well, it is not possible to really have a separate sharp line between the
previous editions eventually.
The previous editions were somehow very different because the systematic reviews were not taken as a basis. Mm-hmm. So my point is that some of the topics cannot be just solved with systematic reviews. There is no evidence, and I always use an example that is gonioscopy, and I use it all the time because there is no evidence, no review, no anything whatsoever that says that gonioscopy is useful at all. Therefore, we still recommend gonioscopy. So back to your question, in some of the topics, we had to stay with consensus. Others that are clearly listed, in the new editions, so we could answer through systematic reviews. And again, looking at all the evidence, I'll give you another example. No consensus among the experts could be reached, for example, on which alternative to use to Goldman tonometry. And this is just a good example of a topic where there are a lot of papers published, but where nobody can really draw a line.
Sorry to interrupt, but because you're saying this, could we think that these guidelines could also be used to identify the gaps in knowledge? For example, in high quality evidence, we haven't, where more research is needed. And so could you consider to develop a document, issue a document, a list of topics where this high quality evidence is still lacking? And this could be a guidance for researchers in the field of glaucoma.
True, and since you, together with Gauti and Ingeborg and Vis, you were all part of the process. This is what was done. The only point is that we could not possibly go through all the questions that we wanted. And so a hierarchy was developed, a priority was developed, so that we started, actually the group led by Augusto Azuara Blanco that started to dig out for the systematic reviews or to produce a systematic review ex novo, went through a list that was realistic and not to the whole list that was theoretically nice to do. And therefore, yes, you are correct. We hopefully in the future continue this process in order to be able to offer reviews, systematic reviews on other clinically relevant topics. But you cannot do a review if there is no published evidence.
Of course. Thank you, Carlo.
You're most welcome.
Your next move to the next presenter, Gauti. You told us about the new class, the raw kinase inhibitors. Does nedosidentil have an additive effect in IOP lowering to PGS, taking into account the mechanism of action being increasing the outflow?
Thank you for the question, Fotiz. Well, yes, it does, because it has a different mechanism, and thus it is considered being a new class. So what nedosidentil does is to relax the cytoskeletons in the trabecular meshworks, which makes it not able to contract, and then the outflow is increased. The prostaglandins, in turn, they use the uveoscleral outflow pathway. So as I think I mentioned in the lecture, there is also a combined fixed combination of latanoprost and nedosidentil underway, and hopefully we'll be able to get that in the future.
Okay, thank you, Gauti. Another question, you highlighted quite nicely that more is not always better. What would constitute the maximum medical treatment for our patients? Do you have any recommendation or any general rule, or how this can be individualized also again?
I think, yeah, the crucial part here is to be individualized, because there will always be exceptions to any rule that is. I think that when you're considering putting the third drop, you should be asking yourself the question of surgery, and definitely when you're adding the fourth or the fifth drop. And I think the main thing to be aware of and to avoid is to delay surgery by putting on one drop after another. So if you do go that pathway because you may have a scared patient or that's afraid of surgery, then you need to have a clear timeline and make sure that the patient doesn't get stuck in some queues that may delay surgery further down the line.
Okay, and another question is, you mentioned that for SLT, there is a recommendation to be considered as initial treatment. Would you have the same approach for ocular hypertension or early versus advanced damage? which may be late in diagnosis and be the initial treatment?
To use SLT, yeah, I would definitely consider it for ocular hypertensives and mild to moderate glaucomas. For more advanced stages, it's part of the plan, but in those you need to be really careful not to delay aggressive treatment. So one needs to keep a lot of visual fields in mind for the first 2 years in order to get the progression rates, and then it can be part of the toolbox, but not as clear evidence as for the mild to moderate glaucomas.
Thank you. Let's move to the talk by Vis. Vis, you mentioned that we should not rely on OCT for diagnosis. I would like to ask you, same applies for progression? And
thanks for the question. And the answer really is OCT alone, yes. Now, what I tried to make clear in my talk is that OCT is an incredibly useful adjunct, both in making diagnosis and in judging progression. So we can easily think of clinical scenarios where an OCT or a series of OCTs will change management. So for example, you've got a patient who's got one eye that's got very well established glaucoma, but with a field defect and structural defects that's been difficult to control, and the fellow eye, which previously has been normal functionally and structurally, develops an OCT abnormality, and then over time you see that getting worse. Well, that really should start to ring alarm bells. But the more of a problem comes.
Regardless of the visual field progression or not?
Well, I certainly think you'd think about treating that eye regardless of visual field progression.
Okay.
You know, it would really challenge your assumption that that was a normal eye, because it's, you know, in the same patient who has progression in the other eye, and you're seeing some sort of progression on OCT. However, you know, I will still reiterate that on its own, it usually isn't enough to make you want to change your treatment paradigm, and certainly not for diagnosis.
Okay, let's now say about, you mentioned for newly diagnosed, there should be 3 tests, manifest glaucoma per year for 2 years. This is the recommendation from the white paper.
Yes.
Is there a similar recommendation for OCT?
Well, we don't have data for OCT. So the equivalent of the white paper has not really been done well for OCT. But what I would say is, you know, since you're bringing the patient along for a visit, and since OCT is a much quicker and easier examination than perimetry, it would make sense to do them at the same time.
I understand that, but there is no clear recommendation on the frequency of OCT.
Well, no, this is because it's more difficult to define what you mean by a significant rate of progression for OCT. The reason being that we don't have good methods of tying structural measures to quality of life. With visual field, it's quite easy to hypothesize that a certain slope will lead to visual disability within the patient's lifetime. Now, the connection between structural measures and that adverse outcome is much more tenuous. I mean, I'm sure we will get there, but it hasn't been done yet.
And related to this, you mentioned that this recommendation for 3 visual fields in a year for 2 year times is a newly diagnosed when you start monitoring them. What about patients later on their follow-up? Should we repeat that at a certain time point or never? Or what if a patient changes doctor and the data are not there? Should the new doctor establish a new baseline?
It's very helpful to establish a new baseline, but obviously the first thing you try to do is to get hold of the old data, or at least some summary from the previous physician as to whether it's a brittle case of glaucoma or a very stable case. Because, you know, if someone comes to me and they've been followed elsewhere and I've got trustworthy information that everything was fine and they were just being seen every year to every 18 months, I won't then see them 4 monthly.
And what about the other question, whether at the follow-up you need to repeat at some point this protocol of 6 visual fields in 2 years' time or not, to reevaluate your target?
I think you may need to do that if you think the patient's gone out of control. But usually what happens in the clinical scenario is if you think things are drifting so badly, you will change your treatment paradigm. Right, and then you will probably gather data more diligently because you'll want to know whether your new treatment has worked.
Okay. On the questions of visual field, there is a question that come in for Vis, whether you want to discourage the use of a fast strategy. Vis.
So we're talking about see to fast and see to faster.
Yes.
I mean, there was some concern in the early days that see to fast was more variable than see to standard, and it probably is a little bit more variable, but you know, it's a much quicker test. So particularly if people have trouble concentrating for the length of time it takes to do a see to standard, at Moorfields we do use see to fast, and I'm sure we will start to use see to faster.
Okay.
So
I think
for questions? Do we have more time for questions? I have a question for Ingeborg, and then there are another couple of questions coming from the system. Ingeborg, you mentioned that trap surgery does not end at the end of the actual surgery, and you need lab revisions, and you have often complications. So why trap is still the gold standard?
Well, I think I clearly mentioned in my lecture that indeed trabeculectomy does need management of the bleb after the surgery. But I also clearly mentioned that the complication rates have gone down and the efficacy on the long run has clearly been demonstrated by long-term studies. So my conclusion there is that trabeculectomy is a very performant surgery still. But it does need some effort after the surgery to manage the bleb. Of course, the latter has been the drive to develop newer surgeries that are probably technically easier, faster, and need less postoperative care. But we also always have to balance their efficacy and safety against each other, and cost effectiveness. So that's why I said that although trabeculectomy is still the gold standard, we need individualized choices, and in some patients, faster and still safe techniques may be justifiable, even if they are less efficacious in patients that have, for instance, less low target pressures.
Thank you. Ingeborg, I would like to ask you about the graph from Aike Ahmed you presented. This graph shows clearly that MIGS are addressed to a different patient population compared to trabeculectomy. Does this mean that we should not really expect studies comparing face-to-face MIGS to trabeculectomy, that this is very different as populations?
That's the thing. Of course, I mean, companies are rarely motivated to do comparative studies, with some exceptions for the related surgeries. However, and I think even if we want to, as scientists, we want to design these studies, that would be ideal. But it is a bit tricky because, as you mentioned, these types of surgeries are used for different types of patients. So it's ethically not always easy to design a study where you will randomize patients into one or another technique independent of their disease status. So that is an important practical issue, I believe.
Yes, of course, but this also a message to clinicians that is a different population of patients.
Absolutely.
And last thing, the cost. You raised the issue of cost, which is very relevant. In the ideal surgery, as described by Fang 10-10-10, cost is not included there. But assuming that we have in one day the ideal surgery, would then be more tolerable in increased cost for that surgery, you think?
Well, this is obviously the ultimate question. If we have the ideal surgery and it has perfect efficacy and is short and has no complications, then probably it would be cost effective. But this is still to be seen, obviously. This will have to be proven. And I don't think we are there yet, the 10-10-10.
Okay. So
I think we are running out of time for questions.
Yes. Yeah. Okay. Next, move to the next session. Thank you very much for your contribution and for your lectures and the contribution to the discussion.
Thank you.
Bye.
Yeah, we are now moving on to the second segment of our webinar. We can still take questions at the end of the next three speakers. So as the moderator for the second session, I would like to now introduce our next speaker, which is Professor Tin Aung. He is Deputy Medical Director, Singapore National Eye Centre, and also the Executive Director of the Singapore Eye Research Institute. And today, Professor Tin Aung will be talking to us on using AI in glaucoma diagnosis.
Good afternoon, ladies and gentlemen. I would like to first thank the organizers for inviting me to give this talk on artificial intelligence for glaucoma diagnosis. My name is Tin Aung and I'm from Singapore. I have no financial disclosures. We are now in the fourth industrial revolution with a range of digital technologies, including the Internet of Things, with next generation telecommunication networks, big data analytics, artificial intelligence, especially using deep learning, as well as blockchain. And with this highly interconnected digital ecosystem, we are now able to have real-time data collection at great scale, allowing for AI and deep learning. Artificial intelligence algorithms can broadly be divided into the older machine learning classifiers, which uses low dimensionality numeric data and are basically to learn from the training sets. And the newer deep learning, such as the convolutional neural networks, which uses high dimensionality data, for example, OCT of fundus images, where you not only provide the initial training, but the machine learning trains and learns new things for new output of both classification and extraction of features. Deep learning has been coined since 2015, and the godfathers of AI have been honored with the Turing Award. Right now, every day in our life, we use a variety of deep learning technologies, including the Amazon Alexa, facial recognition, and others. So the big question remains whether AI can replace humans. And some interesting examples, for example, the game of Go. And in 2016, DeepMind created a deep learning algorithm called Go, which could beat the world champion in Go. And this subsequently, they developed a system called AlphaGo Zero, which learned how to play Go without any human knowledge. And this is purely based on deep learning algorithms. And in 40 days, AlphaGo was found to surpass all other versions and be the world champion in Go. DeepMind also developed a new algorithm for protein analysis, and it will take 13.8 billion years to figure out all the possible configurations of a typical protein. But with deep learning, you could make this prediction much faster, allowing for new applications such as therapeutic targets for drugs and modification of disease progression. The number of publications in the field of deep learning has increased sharply in the last few years, as you can see in the graph on the left. An example in ophthalmology, what AI can see but we can't see. And here is a patient where, looking at the fundus image, we are unable to tell the age of the patient or the gender. But with artificial intelligence, they're able to predict the actual age of the patient to within 2 years and the gender. And in this example, they could predict that this was a female patient. This is something which we can't predict. I would like to recommend these two good reviews of deep learning in ophthalmology, both written by Daniel Ting, my colleague. I will now speak to you about the use of AI for glaucoma. And there's a great potential for using AI for glaucoma management for many reasons. Firstly, many cases of glaucoma are undiagnosed in the population. We know that screening is difficult for diseases with such low prevalence, and so automated systems may help in this regard. There's often difficulties with access to care, growing healthcare costs, as well as shortage of ophthalmologists. And certainly AI would be useful, firstly, to assess for prevalence or assess absence or presence of glaucoma, for triaging, and also from sieving out glaucoma from other optic neuropathies. Of course, in the future, we would like AI to be helpful for monitoring progression of patients, in particular to determine who are at risk of progressing to blindness or severe visual loss. Let me share next with you our study that we published in JAMA in 2017, where we first described a deep learning system for diagnosis of diabetic retinopathy and glaucoma, as well as AMD, from fundus photographs. And this was a paper written by Daniel Ting et al. And the purpose of this study was to evaluate the diagnostic performance of a deep learning system in detecting referable diabetic retinopathy, vision-threatening diabetic retinopathy, referable glaucoma suspects, as well as referable age-related macular degeneration. And this was a multi-center study involving 6 different countries with 11 data sets from both community and hospital-based studies. There were multi-ethnic populations studied, including Asians, Americans, and African Americans. And a variety of cameras were used from these fundus photographs. And for the reference standard, we used professional graders, optometrists, ophthalmologists, and retinal specialists. This was the deep learning algorithm used, which was the CNN VGG19. Altogether, almost 500,000 fundus images were used, including almost 190,000 DR, 197,000 glaucoma, and 107,000 AMD. And this, you can see here the performance of this deep learning system for referable DR and vision-threatening DR with an AUC of almost 0.96. This was superior to that of graders. If you look at the number of cases of glaucoma suspects which we analyzed, we included almost 197,000 patients. And here you can see the breakdown of the different cohorts that we used. And this algorithm was able to have a performance of AUC of 0.94 to detect patients with referable glaucoma. This is the first system in the world to be able to identify 3 major eye conditions. And since then, the software has been licensed to a company called Iris and has been approved for use in Europe as well as in Singapore. Another study from China, from He Mingguang's group, also used AI or deep learning network on 48,000 fundus images to detect referable glaucoma's optic neuropathy. And their study, published in Ophthalmology, also found an AUC of 0.98. Felipe Medeiros did a very interesting study where he used AI to predict the RNFL thickness from fundus photographs and compare it to actual RNFL thickness on OCT. And with this system, the mean predicted RNFL thickness was quite close to that of the actual RNF thickness on OCT, showing you the power of deep learning to predict RNF thickness from fundus photographs. There have been a variety of other studies that looked at AI for structural damage in glaucoma, mostly on OCT studies, and again showed varying success with AUC ranging from 0.85 to 0.98. Interestingly, if you look at some of these studies, you can see that the deep learning networks use not only the visible parameters such as the RNFL, VCDR, or the optic disc, but invisible ones such as spectral noise, tissue reflection, and pixel intensity. And this is an example here is seen here from the heat map analysis that has employed the deep learning system. There have been also several studies which have used AI for detecting functional loss from glaucoma, categorizing normal from glaucomatous visual fields, and showing a good performance of an AUC around 0.92 from one study from Japan. Can AI also detect papular edema? And this is a study which performed recently in a multi-ethnic study to detect papular edema from optic disc photographs. And this was the Bonsai Consortium, which consists of 24 centers from 16 different countries. And we used 15,800 images of 7,500 subjects. And in this system, we used this classification network called DenseNet. Altogether, we had almost 10,000 normals and 2,500 papular edema, and as well as a range of other optic neuropathies. And we found the classification algorithm had an AUC of almost 0.98 to detect papular edema from normals. 0.96 to detect papular edema from normals, which is an excellent result. And this paper was recently published in the New England Journal of Medicine. So, although there are many unique opportunities for digital technology to be used in ophthalmology, there are some issues that remain. For example, patient and public acceptance is still not there. Patients may not trust AI at the moment, and adopting AI in healthcare will be slow and difficult. This is because there are many unanswered areas in AI, including the explainability of the black box, different business models that can be used, medical legal aspects, and medical ethics. In conclusion, I've shared to you today some data that shows you that AI is increasingly used in ophthalmology, and certainly AI shows great promise for glaucoma diagnosis. So the question remains, will artificial intelligence replace ophthalmologists? And I'd like to share the perspective of my colleague Dan Miller, who says ophthalmologists who use AI will replace ophthalmologists who don't use AI. I'd like to acknowledge my colleagues here, especially Dr. Daniel Ting, who leads the AI and Digital Innovation Group at CERI, Professor Dan Miller, Professor Wang Tianyan, Dr. Michael Girard, Liu Yong, and Dr. Tiang Chun. Thank you for your attention.
Thank you, Tin, for a comprehensive overview on the use of AI. Our next speaker is none other than Professor Tanuj Dada, who has helped us to organize all these webinars for APGS. He'll be talking to us on meditation, a polypill for glaucoma. Professor Tanuj Dada is a professor of ophthalmology at the Rajendra Prasad Center of Ophthalmic Sciences from the All India Institute of Medical Sciences in New Delhi, India. On to Professor Dada.
Good evening, everybody. Warm greetings from New Delhi. So I'll be presenting my talks, meditation as a polypill for glaucoma management. I have no financial disclosures. For those of you who are interested in these topics, these are two books which you can go through. Now, you all know that chronic stress can lead to systemic hypertension. But can it lead to ocular hypertension as well? So one of the leading questions that we ask any patient of suspected glaucoma who walks into the outpatient clinic is that, do you take any form of steroids? However, we should also be asking the patient that does he have any psychosocial or emotional stressor, because increase in psychological stress can raise the levels of endogenous cortisol, and this in turn can raise the intraocular pressure. So chronic stress can also lead to an increase in intraocular pressure. And this is especially true for patients of primary open-angle glaucoma because they are already high steroid responders due to an abnormality in the glucoid receptor in the trabecular meshwork. Now, what is meditation? Meditation is basically a technique to focus and quieten the mind to achieve a state of inner calm. There are different techniques of meditation, but our interest has been on what is known as focus attention meditation. Here you focus your thoughts either on the breath, a mantra, a sound, or an image. The studies we have been doing are meditation focused on the breath. In terms of modern physiology, meditation leads to what is known as the relaxation response. This is a physiological response driven by the parasympathetic nervous system. It's a mind-body state to counter the stress response. So is there a need for meditation in glaucoma patients? So I'll be introducing this term, the allostatic load. And I think we are missing the big picture. So allostatic load is basically the effect of chronic stress on the human body. And this is an index of physiological dysregulation. So as the age increases, the chronic stresses on the human body increases, and there is an increase in the allostatic load that can lead to disease. The primary mediators of the allostatic load and the stress-induced pathophysiology are glucocorticoids, catecholamines, and inflammatory mediators, all of which are very important in the pathophysiology of glaucoma patients. Now, how does glaucoma impact the quality of life? We are all aware that glaucoma patients have a poor quality of life. In fact, the moment you tell the patient that he has glaucoma, the patient has an immediate detrimental impact on the quality of life, and he undergoes several negative emotions, including anxiety and depression. So glaucoma patients have high levels of anxiety, depression, and have a poor psychosocial function. And furthermore, this poor quality of life actually worsens when we start therapy due to the side effects of medications. And it's important to understand that there is an association between a faster visual field progression and depressive symptoms. This is something we have been ignoring. So if a patient has high levels of anxiety and depression, he's going to have a faster visual field progression. Now, what are the structural changes in the brain in glaucoma patients? There is a transsynaptic neurodegeneration affecting the lateral geniculate nucleus and the occipital cortex. So the brain naturally becomes a therapeutic target for glaucoma. And recently, the MRI studies with 3 Tesla imaging have shown there is actually a decrease in the size of the visual cortex and the lateral geniculate body, which correlates with the visual field damage. Now, what is the impact of meditation on the human brain? In the last decade, a lot of research has been done on this field, and it has been proven that meditation can actually reverse neurocognitive decline and lead to neurogenesis in the adult brain. This is the first study from the Harvard Medical School which showed that meditation actually offsets cortical thinning. In meditators, the cortical thickness is retained, although it declines in age-matched controls. So meditation offsets age-related cortical thinning, and this has been further confirmed in various meta-analyses. This is one with 21 neuroimaging studies where they documented that there is actually an increase in the gray matter and white matter in the brain of meditators. They calculated what is known as a brain age index using the MRI algorithms. And what they found was that the brain of meditators was actually 7.5 years younger than controls. So meditation is beneficial for brain preservation, and it protects against age-related atrophy. And this is in fact a very important thing, what we find about neuroprotection with the help of meditation for the adult brain. Now, what about cerebral blood flow? Glaucoma patients have a decreased blood flow to the cerebral cortex. And in fact, the reduced cerebral blood flow in the visual cortex is directly correlated with the retinal nerve fiber layer and the visual field damage. So patients have a decreased blood flow both to the eye as well as to the brain. But can we do anything about it? Can we enhance the blood flow to the brain? The answer is yes. Meditation studies have shown that with a simple mindful meditation, half an hour a day for 5 days, there is an increased blood flow to the cerebral cortex confirmed on the SPECT scanning. And this is a study done at our university where we evaluated the oxygenation of the brain in glaucoma patients who underwent 6 weeks of meditation. And what we found was during the functional near-infrared spectroscopy, there was a significant increase in the oxygenation of the brain, both the prefrontal cortex as well as the visual cortex. And there was an upregulation of the brain-derived neurotrophic factor. You can see pre and post imaging increased oxygenation of the occipital cortex after meditation in glaucoma patient for 6 weeks. So that is why we are targeting the brain in glaucoma. And this is very important because not only glaucoma leads to stress, but on the other hand, recent studies have shown that mental stress can also be a cause for vision loss because the human brain controls the stress response with the sympathetics, the hypothalamic pituitary axis, and the immune response. So can we reverse the stress-induced pathophysiology or the allostatic load? The answer is yes. With meditation techniques, you can reduce the levels of plasma cortisol. You can lower the levels of plasma catecholamines. And furthermore, with meditation, you can actually reduce the systemic inflammation and reduce pro-inflammatory gene expression. The reduction of the inflammation is very important because neuroinflammation is involved in the apoptosis of the retinal ganglion cells mediated by a tumor necrosis factor alpha that is increased in glaucoma patients. Now, what about normal pressure glaucoma? These patients have an autonomic dysfunction. There is a predominance of sympathetic activity that is determined by a poor heart rate variability. And this leads to arterial vasoconstriction and a decreased ischemia threshold in the optic nerve. And furthermore, it has been shown that the visual field progression is faster in patients who have got autonomic dysfunction. Now, can we do anything about it? Can we reverse autonomic dysfunction? This is the new frontier of science. And actually, with just 5 days of meditation, you can increase the activity of the parasympathetic nervous system and decrease the sympathetic activity. And this occurs due to a better regulation of the autonomic nervous system by the frontal cortex. And why should you do meditation with focus with breathing through the nose? This is another important concept to understand. When you do slow breathing, less than 6 breaths per minute, the nasal mucosa has a very high innervation. And with slow breathing, you directly stimulate the nasal receptors and you modulate the function of the olfactory bulb. And this in turn modulates the cortical and the brainstem function. So just by slow breathing, you can actually regulate the activity of the autonomic nervous system. And a very nice article published in Scientific American, proper breathing brings better health. So just by slow breathing or focus on breath, you can decrease the activity of the sympathetic nervous system and bring a better state of health to the patient. So bringing all this information together, is meditation useful for glaucoma? We published the first randomized control study for glaucoma patients with mindful meditation. And what we found was that 75% of the patients after 3 weeks of meditation had a 25% reduction in the intraocular pressure, which was very significant. They had an improvement in the quality of life. But what is more significant is you can see nearly a 50% reduction in the levels of cortisol reduction in interleukin-6, and reduction in the tumor necrosis inflammatory markers. Plus, there was a significant change in the gene expression in glaucoma patients. So how does meditation actually lower IOP? Of course, I have told you it can decrease cortisol levels. It can lead to a parasympathetic activation. But there are several other mechanisms. Primarily, meditation can lead to a significant increase in endocannabinoids. And these have a direct impact through a CB1 receptors in the trabecular meshwork. So that can lead to reduction in the intraocular pressure, opening up of the pores of the trabecular meshwork. There is increased levels of plasma melatonin after meditation, and plasma melatonin can directly act on the MT3 receptors in the ciliary body, and this can both decrease aqueous production and also increase the aqueous outflow. In fact, glaucoma patients given oral treatment with melatonin agonists show a significant reduction in intraocular pressure, even though they are on maximum medical therapy. Furthermore, there is a direct action of meditation by stimulation of the hypothalamic arcuate nucleus that can reduce intraocular pressure. And what we did was we asked the patients to meditate, and when they underwent trabeculectomy, we took out a piece of trabecular meshwork and actually evaluated that what is the effect of meditation on the trabecular meshwork gene expression. And this was a very significant finding. We found that there is an upregulation of nitric oxide synthetase, both 1 and 3, in the trabecular meshwork of patients who meditate. So increase in nitric oxide can be one of the main mechanisms for reduction in intraocular pressure, because it can relax the trabecular meshwork and also increase the blood supply to the optic nerve head. And in fact, the main mechanism of action of mindful meditation or the relaxation response is through the release of nitric oxide. So in summary, you have one intervention of mindful meditation, and it can release a number of powerful chemicals from the human brain. So just with one intervention, you can reduce intraocular pressure, you can increase the ocular and cerebral blood flow and improve oxygenation, you can reverse the autonomic dysfunction, reduce inflammation, and actually reverse neurodegeneration. So this is a kind of neuroprotection you're providing to the visual cortex and the human brain. So in summary, what I want to present to you is that although the goal of the glaucoma therapy is to reduce intraocular pressure to target, we should target the patient as well as the intraocular pressure and learn to treat the eye as well as the patient behind the eye. Thank you very much for your kind attention.
Thanks, Tanuj, for covering this topic. In fact, patients have been always asking us about stress causing glaucoma or making it worse. Right now, I would like to now introduce our last speaker, none other than Professor Ivan Goldberg, who is my mentor, and he is currently at the University of Sydney and also Sydney Eye Hospital. And he will be talking to us on something interesting. Dr. Google will see you now. Ivan?
Hello, everybody, and greetings from your Australian and New Zealand colleagues. I thank the APGS and the EGS for inviting me to be part of the symposium. Dr. Google will see you now as the topic I've been allocated. What do our patients learn on the internet? Could it harm them? And how do we try to help them? I have no financial disclosures that are relevant to this presentation. As we are all aware, over the last 20 years, the internet access of the world's population has gone up 10-fold. And people spend a lot of time on the internet, even from childhood. 1-year-olds in Australia spend an hour a day. And if you look at weekdays, 2 to 12-year-olds spend around 90 minutes per day. On the weekends, it increases even further, up to 3 hours a day for 12-year-olds. Now, in health, there are two very different kinds of net searching. There's the sort of searching that we do as doctors and allied healthcare workers and our scientific colleagues, and there are those by the lay population who are our patients. People go to informational websites from governments, health departments, universities and medical centres,
private practices, professional associations and societies, support groups set up specifically for patients, corporate websites, but anybody can create a website and put information on it, and anyone can access it. We also increasingly use journals and textbooks online, and of course, everyone interacts on social media. Here are a couple of search engines that we might use for medical information, and Google itself provides a whole family of search engines added to those provided by publishers such as Elsevier or Walters Kluwer Health and so on. Why do we go as health professionals to the internet? Does the machine beat the human? Well, a group of doctors in Brisbane Googled the symptoms of 26 hard-to-diagnose cases using 3 to 5 search terms from each case. In 15 of those cases, Dr. Google made the correct diagnosis. That's quite impressive. The average doctor has been estimated to carry in his or her head about 2 million facts, whereas Dr. Google has access to more than 2 billion articles instantaneously. So would you use Google to help diagnose the patient that you are caring for? Well, for rare diseases, Google is more often correct even than an experienced physician. Fortunately, however, it cannot substitute for heuristic thinking processes of particularly an experienced physician at this point in time, especially the matching of recognized clinical patterns. It can, however, lead to unnecessary testing and unnecessary anxiety for everyone involved. While they can aid, search engines and diagnostic programs continue to evolve as diagnostic tools, but as yet cannot replace our thought processes. The public also use websites to rate us and to read reviews about us. They can use general websites like Yellow Pages or local.yahoo. They can look at specific physician rating websites like ratemds.com or Angie's List, just to name two. And a number of healthcare providers try to guide patients when they are looking for a doctor to realize that the websites that they are accessing that rate doctors are based on patient reviews and can also promote, without saying so, doctors who have a paid rather than a free profile. And increasingly, healthcare providers are providing patients, healthcare insurance companies are providing patients with guidance as to how to use this information. Fortunately, even though 80% of the people who use the internet for health information use it to access information about their health, a quarter of them, physician rating, it's a small minority, and an even smaller minority would change their physician based on this information. We know ourselves that our patients' thirst for medical knowledge covers an entire spectrum, from people who have no interest at all and simply say to us, "You decide for me, doctor," through to people who have a need for obsessive overload, and of course everything in between. We're all familiar with a patient who arrives with an internet printout of information that she or he has derived, with a pen ready to write down answers to each question in turn. Sometimes patients arrive with a family member to help the patient to take notes, or even their lawyer, as in that case for that photograph. Why do they do it? Well, medical questions can be answered online 24 hours a day with no geographic limits. It's as if the computer flashing cursor invites people to ask anything at all, anytime. It might save time, it might save money, it might save embarrassment. And people feel that it might empower them with some additional information which could prompt them to make an appointment and feel more prepared for that appointment. 2/3 of internet users look for health-related information, and the common conditions are the ones that are sought out most commonly, like diabetes, hypertension, sleep disorders, and medications like analgesics, antidepressants, antihypertensives, antibiotics are the medications most commonly searched. Common procedures like hysterectomy or colonoscopy are looked for most commonly. Sobering facts: 5% of multinational health consumers surveyed use the internet as their primary source of health information, and it was double that, 10% in the United States. 1 in 5 saw their doctors less as a result of that information, and that clearly has ramifications for healthcare providers, insurers, and governments. If you Google the term glaucoma, for example, in less than half a second, you can get 60 million results. The information is unlimited, and it ranges from the good, solid scientific material through to wish fulfillment fantasy and wacky, down to downright demonic and dangerous. And patients have sometimes no idea how to assess the reliability of the claims that are made. As one of our medical journalists here in Australia has highlighted, Dr. Google has the potential to make us ill. Medical site hits are second only in frequency to pornography. Anything wrong, people rush to look up their symptoms on Google. Are those symptoms dangerous? And often there's little relief because they can discover something they didn't know they had to be worried about. And there's a term for this: cyberchondria, web-induced medical anxieties, the unfounded escalation of concerns about common symptoms based on review of search results and literature online. And it can range from temporary neurotic excess through to as an adjunct to hypochondria. So who sorts out this information? Who has the patience and who has the time? The person themselves, their support network, their family practitioner, their pharmacist or optometrist, or us. We really need to recognize how patients access the net and be prepared to offer suggestions about source reliability and to help them to evaluate the value of that information. The negative outcomes that flow from online consumer health information are an increased worry, tension in the relationship we have with our patients if we allow that intrusion of health information to be negative or viewed as negative, and a delay perhaps in consulting clinicians appropriately. So how do we employ strategies to answer this? We can provide consumers with reliable information ourselves. We can educate them on how to evaluate the quality of websites, which we'll talk about in a few minutes. And we can help them present and discuss the information that they've obtained with us or with one of our colleagues in a way which is constructive. We need to be open-minded. We need to communicate the need for the patient to individualize their management, something clearly internet-based resources do not do. And this, if it's done constructively, can help us to reinforce and to build the therapeutic alliance which we have with our patients to optimize outcomes of the treatment program we provide them. Guide the resource use to appropriate sites and incorporate that information thoughtfully into their management. There are a number of absolutely first-class information providers through patient associations around the world, which anyone can access anytime, and we need to provide them with tips to get the information which is reliable and helpful to them. Patients need to be guided to look for the URLs. They need to know that .gov URLs are sponsored by governments and health departments, .edu by universities or medical schools, .org, not-for-profit groups, often with a focus on research. And these are the websites they need to concentrate on because the information is likely to be evidence-based and sound. Even with Twitter, where the URLs are shortened, if they click through, they can see the original link. The patients need to understand the currency of the information that's provided and look for balanced, concise styles of writing, not sales pitches with enormous claims like secret ingredient and miracle worker. Patients need to be helped to understand that if what they read seems too good to be true, it probably is too good to be true. Used appropriately, we can have patients access the net, and both them and we can be happy little koalas. Thank you.
Thank you, Ivan, for covering the topic on Dr. Google, which is very interesting. Right now, we would like to go into the last part of the question and answer. We are slightly over time, but there are quite a number of questions that came in. So I would like to try to cover all of them. The first question is to Carlo. Please share 3 key different things between the 4th and the 5th EGS guideline.
Okay, one is that in the 5th edition, you will find basically no references throughout the text. In the previous edition, we had hundreds of references. This is not because we don't care about evidence, but only because only systematic reviews were quoted. And this is in order to avoid something that, technically speaking, is called hand-picking of references. It's very difficult among similarly high quality papers to really figure out which one is to be quoted and which one is not. So we took a drastic care of that, using only the systematic reviews. And a second big difference that we never did before is that we have a series of things that are called things not to do or choosing wisely. And that was a quite substantial deviation from anything that I ever read before in ophthalmology. And the third big difference is that we listed 14 questions to which an answer, questions that were clinically relevant, and they were prioritized by a group of experts a couple of years ago. And then evidence was collected in order to give an answer with the evidence, and also commentary on the collected evidence and the significance for the clinical care. So these 3 things are really totally new in the 5th edition of the guidelines.
Thank you, Carlo. The next question is to Gauti. Please let us have your comment about the use or abuse of SLT.
So use or abuse of SLT.
Yeah.
Because maybe many doctors are using it maybe too often and in too many patients. Well, I think the crucial matter here is to ask you the question: does this patient need to be treated or followed? And if the answer is that this patient needs treatment, then I think it is valid to use SLT as first treatment, as the LIGHT study has shown.
I think the comment is, if I may intervene, the comment is made and the question with regards to the one who puts the question, put there that many people are treated with SLT being suspects. That's one. So that's another. So that's the abuse maybe in the mind of the person who put the question.
And I think that the same goes for the answer, that if you determine that there is need for treatment, then you could use SLT, but not, of course, if there is no need for treatment, then you shouldn't use SLT.
Question is actually to the panel. In the evaluation of a newly diagnosed glaucoma, is there a role for doing sleep study or evaluation for carotid artery stenosis? Maybe Tanuj, you want to answer that?
Yeah, I think as a routine, you don't need to do a sleep study. If a patient is obese, he has a risk factor. If the family is saying that he has excessive snoring at night, and the intraocular pressure is apparently normal, but disease is progressing, then maybe a sleep study may be indicated. And carotid studies are indicated if a patient has a normal pressure glaucoma and has progression despite normal IOP. I think then you can do a carotid imaging for occlusive disease, but not as a routine.
Yeah, and the last question is to Tanuj as well. What other alternative therapy routes, which is like sport or diet or sleep, do you recommend for treatment of glaucoma?
So I think there is no evidence-based regarding diet or exercise or any alternate therapy. The only issue is that what I stressed was what is known as the allostatic load. So as you age, your body responds to stress in a very bad manner, and you have high catecholamines and high endogenous cortisol. So just adopting a healthy lifestyle by regular aerobic exercise and introducing a bit of deep breathing and meditation can lower your stress, and that is helpful for glaucoma because it lowers both cortisol and catecholamines. So that is good enough. As far as diet, there is no evidence regarding any dietary change that can impact glaucoma.
Thank you, Tanuj. I think we are now out of time. I would like to thank all the speakers for joining us at this useful webinar. I would like to announce that APGS will be conducting more webinars in the future. So the next one will be on 6th December in collaboration with the American Glaucoma Society. And there's one as well in February, which is in collaboration with the ISGS. So keep these dates that is being proposed in your calendar. And again, I would like to thank the European Glaucoma Society for joining us in this EGS and APGS webinar. Thank you all.
I would like to thank the Asia Pacific Glaucoma Society for inviting EGS to this great event. Thank you for organizing this.
Thank you, Fotiz. Thank you.
Thank you.
Thank you very much. Have a great day.
Excellent. Lovely to be part of this. Thank you.
Thank you.
Thank
Bye-bye.
you.
Bye-bye.